there is penetrate.
Larger.
What other feature?
Penetrate the capsule.
Huh?
Penetrate the tumor penetrate the capsule.
Okay, here you can see damage to the capsule. Okay. What else? Most obvious feature.
Appears.
Very important feature, the difference between these two and the previous one.
Necrosis.
Yes, you can see necrosis and the cavities. You can see these cavities. It's not a solid looking tumor. It is cystic with some solid areas. It is more cystic and multiple cavities, and it is necrotic also, and also capsule is also invaded. And it is relatively less necrotic, and you find these cavities of cystic degeneration in some solid area. And this is normal tested at one margin. So seminoma is solid looking tumor. In the seminoma you don't find these cavities. So this is the basic difference. Yolk sac tumor, embryonal carcinoma, they appear like this. Or even if choriocarcinoma is there, it is totally necrotic and hemorrhagic. So this is image or gross image of a mixed germ cell tumor. If I show you this image only, for example, and I ask you which type of germ cell tumor it could be, then it is not seminoma at least. You can say any other. You can say embryonal carcinoma, it is acceptable. You say yolk sac tumor, it will be acceptable. Choriocarcinoma is very rare, therefore you will not take the name of choriocarcinoma. It is very rare in male. And it is mostly hemorrhagic and necrotic choriocarcinoma. Therefore, the most likely it could be embryonal carcinoma, or it could be yolk sac tumor, the other two. And then we can relate with the age. Yolk sac tumor is under 3 years of age. If I mention the age, and this tumor, then which germ cell tumor it could be? A child of 2 years of age presented with testicular swelling, testis is removed, which shows the following morphology, then you can say it is most likely a yolk sac tumor. You will not write seminoma in a 2 years child or 3 years or 5 years child. Seminoma is a third or fourth decade tumor, above 35, 40, like this age. Now this is embryonal carcinoma. This is a good picture. In my lecture there was not a good picture of. These are the, you can see the large cells having basophilic cytoplasm, not clear cytoplasm. Cytoplasm is basophilic in color, bluish in color. And you can see they are forming solid area and some glandular structures like with the lumen in them. They are forming some glandular structures or tubular structures. So these are the features of embryonal carcinoma. Embryonal carcinoma comprising of large cells with basophilic cytoplasm and nucleus with prominent nucleolus in them. They form a glandular or tubular structure, or sometimes cords of cell. They may form some solid sheet-like areas. And which tumor marker is associated with this embryonal carcinoma?
Alpha.
No, it's in your.
It's not alpha fetoprotein. I think this embryonal carcinoma is usually, I mentioned you, it is not always pure. Only 2 to 3% of the cases have pure embryonal carcinoma. It is always mixed. And it's combination with the seminoma, or in combination with the teratoma, or some other germ cell tumor. Therefore, the marker will be raised according to the other component which it has. Now here you can see, there is a terminology over here in the previous slide. Teratocarcinoma. When you find teratoma with embryonal carcinoma. If you find teratoma with embryonal carcinoma, you find cartilage, bone, and part of the tumor is showing embryonal carcinoma or yolk sac tumor component. Now here what you see in this image. Why we call embryonal carcinoma with teratoma? What components of teratoma are visible here?
Tissue.
What is this structure?
Cartilage?
Yes, it's a cartilage. This is cartilage. What are these structures? What it look like? Huh?
No.
This.
Muscles.
No, this. Yes, glandular structure. Very good. Epithelial cell. Epithelial cells, glandular structure, and these epithelial cells, they does not have a normal nuclei. You can see the multi-layering of nuclei, and this is basically low power image. This is the embryonal carcinoma component. This is the neural tissue, mature neural tissue, cartilage, stromal tissue, and this is embryonal carcinoma component. And that's why we call it as embryonal carcinoma with teratoma. This is embryonal component, and the others are component of teratoma. Neural tissue over here, glial tissue, we call it as a glial tissue. This is cartilage, and these are stromal cells, fibroblasts, and these things. And here we find epithelial component with malignant looking cells, and this is the embryonal component of this tumor. Therefore, on the basis of this component and this component, we call it as a mixed tumor, or teratoma with germ cell component. This is yolk sac tumor. These glomerulite structures are high power, and these is small cells. They are forming pods or these net-like pattern. Reticulate pattern, proper word is used for it. But in my lecture slide, we have a good image of these glomerulite-like bodies. You will be having some clue with the image. If there is MCQ with this or this, I give you some clue, some hint. If you just consider, then maybe a tumor marker is supporting the image, maybe history is supporting the image, maybe gross morphology is supporting the image, maybe age of the patient is supporting the image. Then you can make the diagnosis easily. If you're just looking at the image without concentrating on the question, then you will be in trouble. Therefore, you just carefully read the question and look at the hint. The question will not be difficult. They will be inshallah very easy. But with your own mistake, you make it wrong, then I can't do it. But just carefully study that. So these are some of the images. Yolk sac tumor, embryonal carcinoma with next component. This gross morphology. This gross morphology is important, and then seminoma gross morphology is important, and the image of seminoma is important. This one, at least this one you must remember. Came very late.
You finished it?
We finished one practical, one lecture. Your attendance will be for the third practical.
Okay.
I gave you the attendance sheet?
No.